All right, so I am going to go ahead and get started since it's right about 2 o'clock. So it's really nice to have the chance to speak with you guys all today. My name is Dr. Krista Eschbach, and I am Assistant Professor of Pediatrics and Neurology at Children's Hospital, Colorado. I also oversee our EMU and EEG laboratory. So I'm really glad to be able to talk with you guys about some highlights of pediatric epilepsy syndromes. Specifically, we're going to talk about a few in the neonatal period, a few in infancy, and then also some that occur when people are a little bit older, kind of in later childhood. And so I'll highlight just a few of them. There's many that we won't get a chance to discuss, but I want to, have a time to go over a few of them. I also really want to thank Dr. Kristen Park, who you'll meet tomorrow, and other organizers for Epilepsy Awareness Day for giving me this opportunity to speak with you guys today. All right. So to start with, we're going to first talk about epilepsy diagnosis, and a lot of you are familiar with this, but how do we get that diagnosis? What is an epilepsy syndrome? Some examples of different epilepsy syndromes, like I mentioned, and then resources and support, which there's some great resources and support depending on the epilepsy syndrome available to help provide additional guidance. All right, so starting at the beginning, I just want to make sure we're all on the same page about, what is a seizure. Often it can be described in many different ways and may look very different for each child, but it's a transient occurrence of signs or symptoms. So the things that they do that are a result of abnormal, excessive, or synchronous neuronal activity in the brain. Most seizures are self-limited, lasting seconds to minutes, although that's not always the case. And there can be multiple different types of seizures, which we'll talk about in a little bit. It's important to also consider, though, what things can look like seizures, but that are not seizures. And so we won't focus on this, of course, since we're here to talk about different epilepsy syndromes, but there are this is the different things that your doctors are thinking about when they're deciding, was this a seizure? Was this not a seizure? Is kind of the first step in the evaluation. So could it have actually been syncope or an episode of passing out for different reasons? So in children, sometimes breath holding spells can cause that and can look similar to seizures. If someone's really dehydrated, if they have abnormalities in their heart rhythm, for example. There can also be sleep disorders that can sometimes look similar to seizures at night. And so trying to tease out the difference between those two. Sometimes there's also different GI disorders that can actually look similar to seizures. So something called Sandifer syndrome, which is related to reflux, and you can get back stiffening and arching in infants. That can sometimes look very much like a seizure. Other things that can have symptoms similar to seizures are abdominal migraines with that kind of nausea, pain that can happen, that sometimes can be a part of some auras that happen before seizures. Cyclic vomiting syndrome, which is where kids can have repetitive vomiting. That can also sometimes be hard to distinguish from a seizure as well. There's other things that are neurological in origin that can look like seizures as well. So things like tics, stereotypies, which are repetitive movements that people do that are kind of more of a habit. Sometimes it could be like this, or a shuddering type movement. Movement disorders can sometimes look like seizures as well as migraines with auras, or the term complicated migraine. And then lastly, the other thing that people are thinking about when we're thinking about seizures that can overlap is things that have some of our underlying psychiatric diagnoses, and that can include things like non-epileptic seizures, which falls into neurological as well, but also daydreaming. Things like ADHD or inattention can sometimes look like staring types of seizures. Panic attacks and behavioral, especially in babies, can sometimes look similar. So it's important to think about these other things as well if you're when your child or family member or yourself are being evaluated the first time for something that could be a seizure. But if it is a seizure, then it's important to also think about what causes it. And there's lots of different reasons for seizures. And this slide is a focus more on the cellular level in our neurons, what is causing a seizure. So on a cellular level in our neurons, there's too much excitation. And so as part of that, it means from a ion standpoint, you're having too much inward sodium current and calcium currents. The excitation is typically mediated by two neurotransmitters called glutamate and aspartate. Or on the flip side, you can have too little inhibition. And so that is related to the inward chloride current and outward potassium currents, which is the K, and is mediated by the neurotransmitter GABA. And these things come into mind when we're thinking about different medications that can help treat our seizures as well. And like I mentioned at the beginning, there's many different types of seizures. And so this is the updated 2017 classification of seizure types from the International League Against Epilepsy. And we divide our seizures into focal onset or generalized onset, or sometimes you can't tell exactly if it's focal or generalized, and so unknown onset. And when we think about a generalized onset seizure, that means the activity is coming from everywhere all at once and rapidly involving all parts of the brain, compared to a focal onset seizure where the activity is starting in just one area. It may still spread throughout both parts of the brain, and that would be the focal to bilateral tonic-clonic, or it can just stay in that one area. And that relates to the different symptoms that someone experiences depending on where that activity is spreading. And so this is the abbreviated or basic version of the seizure classification. In a couple slides, we'll see the expanded version, and the expanded version gives in a little bit more detail of different symptoms that you can experience with focal and generalized onset seizures. Like I mentioned, for types of focal seizures, it really varies depending on the type, the part of the brain that is involved. And so you can have frontal lobe seizures, which can have some of the different symptoms listed here. So you can get autonomic symptoms, which is vital sign changes, sweating. There can often be, especially it involves the motor cortex in the frontal lobe. You can get head or eye turning to one direction, as well as stiffening of an extremity. And clonic jerking. You can also have what we call hyperkinetic, or a lot of movements with frontal lobe seizures. That can be also sometimes have preserved consciousness as well, and often can occur out of sleep. So that can be characteristics of frontal lobe seizures. Parietal seizures, so our parietal cortex is involved in sensation. And so when you have seizures from that area, you can get tingling or tightness sensation that typically is developed in a very clearly defined region of the body and is consistent over time when you experience that. And so if you get tingling and it's in a variety of different places, that's going to be something that's less likely seizure, compared to if it's always in the same distribution over time and is short in duration, like seizures. And often with some other symptoms as it spreads. Temporal lobe seizures can have some abdominal symptoms. Kind of a rising abdominal sensation can be experienced, and then evolving to having some repetitive mouth movements or lip smacking or swallowing, and typically impaired awareness where they aren't responding normally to you. And there can also be auditory auras or taste auras, so hearing things that are sounding different or different tastes. And then also some psychic auras too, so feeling unreal and strange sensations as well. Deja vu can happen with temporal lobe seizures. And lastly, occipital lobe seizures involving the occipital cortex, which is important for our visual processing. You can get visual changes, bright or dark spots. You can also have loss of vision. Sometimes these types of seizures also can have some other symptoms too, in relation to vomiting and some of the autonomic symptoms that we discussed earlier. So all this really depends on the part of the brain that's activated and where the seizure is spreading to. And that's why when you see your doctors to talk about your seizures, they're really trying to ask very much, what is each step along the way is what happens, so that we can better understand where they're coming from. All right, and here's the larger classification that I mentioned that we were going to touch on, where you can see all the different types of focal onset seizures with motor onset or non-motor onset, and can be either aware or unaware or impaired awareness, and then generalized onset seizures as well. And so part of why I wanted to highlight this as we talk about epilepsy syndromes is that based on the types of seizures, we're able to better understand the epilepsy syndrome. And so I thought it was important to first go over a little bit about the different types of seizures that we can have. All right, so how do you get a diagnosis of epilepsy? Many of you are probably familiar with this, but I just want to make sure we're all, again, on the same page as we're talking about epilepsy syndromes. So you are the requirements are to have at least 2 unprovoked seizures more than 24 hours apart. It means you can't have the seizure because of a head trauma or fever, for example, for young kids, or other provoking factors such as electrolyte disturbances, substances or medications, anything like that. You can also have a diagnosis of epilepsy. This was a change in 2014, where you can have 1 unprovoked seizure, but have a probability of recurrent seizures of at least 60%. And so how that number 60% came about is that after 2 unprovoked seizures, your risk of another seizure is around 70% or so, depending on some other factors. And so this number of at least 60% seemed to be, well, if you have 1 and you have that high of a risk of having another one, that you could also meet the criteria for epilepsy. And you get at this number by 60% typically based on MRI or EEG findings. And so if you have a change on your MRI where it looks like there's something there, a difference in how the brain formed or an old injury or something that had happened, that maybe your seizures are coming in from there, that would push over to the epilepsy diagnosis. Or if on your EEG you have an evidence of a tendency for seizures, so what we call spikes, coming from one area, or maybe having generalized spikes on your EEG, that would also put you in the area of having a greater than 60% likelihood of having another seizure and meeting the diagnosis of epilepsy. And part of why that was important is because then for some patients, you may decide not to wait for that second seizure and to start a medication after the first one, if some of this additional testing comes back as abnormal. The other way to get a diagnosis of epilepsy is if you have an EEG that provides a diagnosis of a specific epilepsy syndrome. And so again, we'll be talking about a variety of epilepsy syndromes today, and that will be the focus of what we're going to discuss. All right, so how common are seizures in epilepsy? I think you guys all know this probably pretty well, but 5% of children will have a seizure by 20 years old. 10% of the population will have a seizure at some point in their lifetime. We see higher numbers of seizures in the elderly and very young, so in the neonatal period when we're talking about very young. And then 1 to 2% of the population has epilepsy at any given time, and 1 in 26 people have epilepsy in their lifetime. And over 43,000 people in Colorado have epilepsy. And so I think these numbers are just important to keep in mind about how common it really is, and that there's a lot of people out there, as you guys all know, who have seizures and epilepsy. All right, so now as we get to, oops, I don't know if you guys can still see my slides. Hang on. Hopefully they're back. All right, now as we get to hang on one second. It looked like it stopped sharing. Let me just make sure. There we go. All right, now as we get to talking about epilepsy syndromes, I wanted to outline this figure that goes over, it was the Epilepsy Classifications from a couple of years ago. And so we start with the different seizure types like we discussed, so focal, generalized, or unknown. And then you try and think about the type of epilepsy. So is it a focal epilepsy? And often, you know, focal seizures, you have a focal epilepsy, but sometimes you can have combined generalized and focal. And then if you have generalized seizures, does it mean you have a generalized epilepsy? So thinking about the epilepsy type. And then the next step at the bottom of the screen here is getting to that epilepsy syndrome, which I'll define on our next slide for you guys. Other things to think about is on the side here on the left is that there's comorbidities that go along with epilepsy that are recognized to be a part of the syndromes when we talk about them. So those can be things like learning differences to expect or other health concerns that we know can happen. And then on the far side on the right here is when we're thinking about the different causes. So etiology, the different causes of epilepsy. And so this figure really put together all these different features so that we can talk about our epilepsy syndromes and epilepsy in more detail. All right, and I apologize to you guys all again. Having trouble with my screen share. So one second. Let me see if I can get this to show right for you guys again. All right, some of you, one of you is on video. So if you can give me a thumbs up if you see my right slide again about what is epilepsy syndrome. Perfect. Okay.
We can see it.
Okay, perfect. Sorry, I think something happened on my computer and it threw everything off where I couldn't see my notes again or anything. So, all right. So what is an epilepsy syndrome? So an epilepsy syndrome, which obviously is what we're here to talk about, right? But what does that actually mean? So it's a cluster of features, including the seizure types, like I mentioned, the EEG findings and imaging features that tend to occur together. It often incorporates certain age-dependent features, such as age at onset and remission, seizure triggers, if there's any sort of diurnal daily variation, and sometimes prognosis. And it may also have a distinctive comorbidity, such as intellectual and psychiatric dysfunction that we know are part of those. And I think this is important because often the questions are, well, what to expect? And is this something I'm going to outgrow or not? And if we're able to put things into a specific syndrome, it lets us know a little bit more about those answers. It also lets us know about sometimes what medications may be more helpful or what another evaluation we need to do. Everyone doesn't always fit into a clear epilepsy syndrome. There was that unknown category on the epilepsy types, and that makes it a little bit tricky, but we have many epilepsy syndromes that can help answer these questions. One thing to note is that the Internationally Against Epilepsy has not, at this point, has not had a fully agreed upon diagnostic criteria for the various epilepsy syndromes, although there's a proposal in process and that should be finalized by early 2022. Although they do have a webpage that you guys, I'll give you a reference to at the end, called Epilepsydiagnosis.org, that outlines kind of general recommendations for each of the syndromes and how to meet that diagnosis. And basically what's going to happen in early next year is that there'll be a final recommendation from a task force that has really made to standardize how do you make, what is a part of one syndrome compared to another syndrome. So to standardize that a little bit more. And then as we're talking about epilepsy syndromes and how it may relate to prognosis, I just wanted to highlight one other thing that came out with the classification of the epilepsies a few years ago, was that the idea that epilepsy is not considered cured per se, but epilepsy can be resolved. And this definition comes for individuals who have an age-dependent epilepsy syndrome, but are now past the applicable age for which it occurs, or those who have remained seizure-free for the last 10 years with no seizure medicines for the last 5 years. And so this idea of resolved, I think, is really important. And some of the syndromes, as we talk about them, you'll see that there's a certain age that we expect that epilepsy syndrome would end. And so if that person's at that age and they haven't had any seizures and are past that age, then we consider it resolved. And in general, anti-seizure medications are often continued until at least seizure-free for 2 years. The exact duration may vary based on age and the cause of seizures. So that's something you'll be able to keep talking about with your doctors if that applies to you. All right, but first things to talk about, an area that I have a lot of interest in is neonatal seizures and epilepsy syndromes. And so I could probably spend the whole hour talking on this, but I limited myself to just a few slides because it may not apply to everyone. And first, I just want to highlight the idea of neonatal seizures. So those are seizures that happen from birth until 44 weeks gestational age, so about 28 days of life in babies who are born term. These can often be provoked and are not actually epilepsy. And so we're going to talk about some of the neonatal epilepsies, but I just wanted to make this distinction first, is that causes of neonatal seizures are often provoked. So things like hypoxic ischemic encephalopathy, that means there's a period of time where maybe the baby didn't get enough oxygen around delivery. Things like stroke or blood in the brain can be causes of seizures in this age group. Neonatal epilepsy actually only accounts for about 13% of neonatal seizures, and so is a much smaller number. I put a picture here of our neonatal neurology program and who provide care for our patients who not only have neonatal seizures, but also are in the NICU and then need to follow up with neurology outside of the hospital. And so I have our team there, and then I'm the one who is focusing on neonatal seizures and epilepsy of the group. All right, so some of the neonatal epilepsy syndromes. So there's 3 I'm going to highlight today. The first is a self-limited neonatal epilepsy syndrome. And then the other 2 do not have that same course, and we'll get to them. So for self-limited neonatal epilepsy syndromes, there's kind of two names that this used to be called. So benign familial neonatal epilepsy, or benign neonatal epilepsy, when someone else in the family didn't have this same chain, didn't have seizures as well. And so this often presents with seizures in the first week of life, typically kind of onset around day 4 to 7. Importantly, these babies have a normal exam between seizures, so they look completely normal. They're awake, interactive, feeding well, and they often can have focal clonic seizures with jerking movements, and sometimes for some of them can have several per day when they are occurring. And they often resolve on their own. This is why it's called self-limited, by about 4 to 6 months, sometimes even younger. There's a few genetic causes of these types of seizures, and the genes are listed there. Importantly, some of these genes can also cause a more severe type of epilepsy and seizures. So unfortunately, it's not that, for example, all the KCNQ2 mutations do not all cause this self-limited epilepsy. Sometimes a mutation in that same gene can cause a more severe type of epilepsy. The EEG features, often about 10% will be normal between the seizures. They may have some subtle abnormalities, but it's not a dramatically abnormal EEG, but might have some mild abnormalities. And the treatment is based a little bit on, if you identify a specific gene, then you may be able to target what the best treatment is. But often one of our medications called oxcarbazepine can be helpful in neonatal seizures, a self-limited type, specifically with some of the mutations like KCNQ2. Again, if you have a specific gene that was identified as the cause, that might help target what medication to use a little bit more.
So excuse me, Dr. Eschbach, I hate to interrupt. Can you make it full screen? I think some people are having some issues seeing it.
Oh, I thought they
It's
could
only in
see
the
it full
corner.
screen.
No, only in the corner we can see your nose.
Really? What
Yes.
happened? I got a thumbs up. Okay.
We can see it. It's just a little small.
Huh. I don't know why it's small. Hang on. Thanks, Lauren. Let me try this another way. It had all worked fine. And is that better or no? Or you still can't see anything?
We can't see anything.
Okay. Just I see stuff. That doesn't help. Okay. Hang on 1 second. Okay, so now you can see all of my slides. Is that right or no? Is it not?
We can see all your slides to the left and then your main slide. Is there a way to make that? Can you select that use slideshow option?
Yeah. Where?
On the top, your mouse just on the top bar.
The Zoom thing is in the way. That's what's happening. Okay, hang on. Let me see.
Somebody at a different Zoom had the same issue, and it's not that screen. If you go back to the original screen on the top toolbar that's black, and it should say swap display, and they have to click on that and click in something in the swap display.
Swap screen. I apologize, you guys, that it's been like messed up the whole time and you can't see what I'm doing. You're like, what is that small font that she's showing? Who knows? Oh, okay. There, are we good now?
That's perfect.
Oh, thank goodness. Thanks for someone. I just see that someone probably said to say something in the chat, but I also can't like see the chat once I start talking either. It just kind of goes away. Okay, so you guys see the big screen. Everyone can read it now.
That's perfect. Yep.
Okay.
Thank you.
No, thanks for jumping in. I'm going to try and go back to a slide because I think I ended up skipping ahead and we won't have sense where we're at. So after we're talking about the self-limited neonatal epilepsies, the next ones that we talk about fall in this category of developmental and epileptic encephalopathy. And so I just want to mention what that means. I don't, know if anyone has heard of that before, but encephalopathy is a term that's used when there is a condition in which the functioning of the brain is affected by some agent or condition. And so this can be from a variety of different things, and is a term that you can see related to infections of the brain or inflammation or variety of different reasons. And so this term is not specific to epilepsy, but I'm going to explain it and how it can relate to seizures. So the term epileptic encephalopathy is when the epileptic activity itself contributes to severe cognitive and behavioral impairments above and beyond what might be expected from the underlying cause alone. And that used to be a term that would be talked about with certain epilepsy syndromes. And more recently, it's been redefined as this developmental and epileptic encephalopathy, like I mentioned. And the developmental component is that there's a change in development or developmental impairment without frequent epileptic activity associated with regression or farther slowing of development. And so the updated term really includes both of these ideas, developmental and epileptic encephalopathy, in which both of the above factors play a role. Often there's a question of, well, how much is due to the underlying reason for the seizures, which may get at that developmental part that's influencing learning and development, or that encephalopathy, and how much is due to seizure activity or that epileptic part. And it's often hard to kind of disentangle how much is from each of those, but we do know that both of these things can play a role. And so it's a term I just want to introduce. I know now that it sounds like you guys have audio and can, jump in and ask questions and stuff too. So please feel free to, if you have any questions. We'll talk about this in relation to the next two epilepsy syndromes, though, that we're going to talk about. So one is early myoclonic encephalopathy. So in contrast to the self-limited neonatal epilepsy that I talked about, these children tend to have what we call an epileptic encephalopathy, and so are more sleepy than we would expect, may have trouble with feeding, may not have normal kind of tone in terms of how tight or relaxed their muscles are on exam. They have a myoclonic seizures as their predominant seizure type, but they can also have other seizure types. Onset is typically in the first 2 months of life, but 50% within the first 10 days. And this is often can be due to metabolic, which means how your body is kind of using and metabolizing different energy sources, or genetic changes. Sometimes can also be to differences in how the brain formed. And in contrast to the self-limited types of neonatal seizures who had a relatively normal EEG, this EEG tends, for children who have this, tends to be pretty abnormal and often can have a suppression burst pattern, which I'll show a picture of later on. And the medications to treat this depend on the underlying cause and type of seizures. And so it's not, I can't say, for this type of epilepsy syndrome, there's necessarily one specific medication, but it's going to depend on if there is an underlying cause identified, and then, are they predominantly having myoclonic, or over time, they may have other seizure types too. And so that may change. And then the next one to talk about that's somewhat similar is something called Odahara Syndrome. That was the former name. It's now been renamed early infantile epileptic encephalopathy. And so again, these babies can have differences in their learning and development relating to why the use of that term epileptic encephalopathy, and so do not have a normal neurologic exam. In contrast to having typical myoclonic seizures, they actually have typically tonic seizures. And so instead of kind of a brief, more rapid jerk, that's a longer stiffening that can last and occur. They often will have other seizure types too. And the onset of this is also typically in the first 1 to 3 months, but can sometimes be in that neonatal period. Often there can be a difference in how the brain formed as a cause of this, but also could be genetic. And so those are testing that if this is something that anyone that has a concern for diagnosis of, they'll have had additional MRI testing, often genetic testing as well. This EEG also is not going to be normal and is going to have that suppression burst pattern. The medications, again, depend on the underlying cause, and there are some treatable metabolic disorders that can present this way. And so it's important to evaluate to see if there's anything that you could treat different and help reduce the severity of this type of epilepsy. And here's an example. I'll have a normal EEG that we'll look at a little bit later, but this is kind of a burst of abnormal activity on the EEG that you see on the top right. And then it's suppressed, so it looks pretty flat in between, and then a burst of activity. So that's that suppression burst pattern. And then here's also, as I mentioned, there can often be differences in how the brain formed. And so this is from this article by Pavone, but this picture of the MRI shows that there's differences in the folds that are around the brain, and it doesn't have the normal gyri and sulci, which are the folds that go around the brain. And so when you have this differences, which can again, there's a variety of different structural changes that can cause this. You can result in having this type of epilepsy. All right, we're going to move on to a couple infantile epilepsy syndromes. Again, I'm doing a little bit of a smattering of different ages. There's not enough time to cover them all. And so now we're going to talk about severe myoclonic epilepsy of infancy. The other name is Gervais syndrome. And I thought this was an important one to touch on because it's been an area of active research and really exciting change in epilepsy. And I hope that we see this same change and advancement for other epilepsy syndromes as well. So typically with Gervais syndrome, you have onset of seizures prior to 18 months. You initially have prolonged seizures involving shaking of one side of the body that can be triggered by heat or fever. You can have alternating side of onset. So sometimes maybe it's the right side and sometimes it's the left side. As kids get a little bit older, you can see some other types of seizures. They can be sensitive to light and patterns for these children. As children who have Gervais syndrome become older, the epilepsy severity does tend to decrease into adulthood, but often remains present. So again, that gets at with our epilepsy syndromes. Sometimes they can influence what we know about prognosis. Development is often normal at onset, but can slow around the time of the myoclonus, and also when there's other seizure types like non-convulsive seizures such as absence seizures. There has been reports in the literature of over time seeing some ataxia, so trouble with gait or a more crouching gait, difficulties with appetite that can develop over time as well. And this is often due to a genetic mutation in the SCN1A gene. Importantly, just like I mentioned earlier with the KCNQ2 gene in our neonatal epilepsies, SCN1A gene mutations most often present with Gervais syndrome, but can also present with other types of epilepsy. So with something that's called generalized epilepsy with febrile seizures, and also more isolated febrile seizures as well. The EEG features of Gervais syndrome. So typically when children are younger, they have a normal background, meaning there's not any slowing that we see in the EEG, but we do see a tendency for seizures with discharges in about 25%. And then as they become older, there can be more slowing seen in the EEG background. And then over time, there can be that photosensitivity where with the flashing lights on the EEG, we'll pick up increased activity. And this is the exciting part in terms of our treatment options. So in the past, we would have what I have there under step 2, so valproic acid or clobazam as first line therapies. And those are still good therapies at this point, but we also have newer medications too that can be added and also considered for this condition. So stiripentol and fenfluramine. And then there's ongoing clinical trials as well as we are understanding and learning more about Gervais syndrome for other treatments too. And so I think this is just a really great example of the syndrome of how I hope that over time, we're able to have more targeted therapies for some of our other epilepsy syndromes as well. All right. West syndrome is another infantile type of epilepsy that presents with a different type of seizure we haven't talked about yet, but infantile spasms, which is a type of seizure where you kind of get a rapid either flexion or crunching or extension that lasts just a couple of seconds and can cluster. You get an EEG pattern called hypsarrhythmia. That's a very disorganized and chaotic EEG pattern. And then typically with the onset of this, there'll be arrest of normal development. That's kind of the third aspect that puts it into the syndrome of West syndrome. This is a picture of the hypsarrhythmia that I had mentioned. So here on the bottom right is a normal EEG for comparison. And then up here, you see this and over here too, the waveforms on the EEG are higher in amplitude. So if we're measuring from top to bottom, and then there's also these things in here. So here where it looks really pointy, those are things called spikes. And you can see them in multiple different areas if you're looking through the tracing of the EEG. And so that's that hypsarrhythmia. Typically, kids with West syndrome present in the first year of life. It can occasionally happen a little bit later than that, but the highest incidence is in the first year of life. Can occur in patients with developmental delay or an abnormal neurologic exam already. So some of our patients who I talked about before with Odahara syndrome can kind of fit the criteria for West syndrome as they get a little bit older. Or these can happen in a child who has normal development before the start of their spasms and has a normal neurologic exam when their spasms start. The cause can be structural brain abnormalities, so meaning differences in how the brain formed, remote injuries, can also be genetic causes as well, like we've talked about. The EEG I had mentioned and showed you guys pictures of already. And then the treatment, this is one type of epilepsy syndrome where our initial first-line therapies are different than for some of our other types of seizures. So again, we're thinking about the syndrome, and the seizure type can help guide treatment. So often we'll look at things called hormonal therapy, which is actually steroids, so prednisolone, or ACTH, which is adrenocorticotropin releasing hormone, or vigabatrin or vigadrone as first-line therapies for infantile spasms with West syndrome. In patients who have tuberous sclerosis complex, vigadrone is first-line treatment and can be more effective. All right. So now we're going to go into childhood epilepsy syndromes. And so some of what we have talked about, as you can tell, have been a little bit more severe types of epilepsy with many different types of seizures for some of them. We're now going to talk about a type of epilepsy that's a little bit more common than the other ones we've talked about, and typically has predominantly one seizure type. So childhood absence epilepsy accounts for 10 to 17% of all children with epilepsy. And so it's one of our more common types of childhood or pediatric epilepsy. And typical absence seizures with behavioral arrest, which that's when there's staring, can happen, often lasting, maybe 10 seconds, although sometimes longer, and sometimes there can be some mouth movements with them or eyelid fluttering. Before treatment, they're often multiple times per day, but again, can be brief and subtle and hard to know that this type of seizure is happening because they're so short and just that staring for some children. There's a specific EEG pattern that I'll show you guys, and the typical kind of age of onset is about 4 to 10 years old. Some children have an earlier onset of absence epilepsy, and that's called early onset absence epilepsy, but this is kind of the main age range for childhood. Most children are pretty responsive to treatment, and we'll talk about some of the treatment trials for this condition in just a minute. So here's an example of an absence seizure on EEG. And so here, just give you guys a little orientation to the EEG. All right, so you have the spike and wave discharge. That's kind of the pointy part. I don't know if you guys can see my mouse, but hopefully you can. I realized I was using it on the other screen at first, but there's a spike and then a wave. And you can see it throughout all of these electrode contacts. And the little red lines are a second. And so in between each second, it also gives us a frequency of how often those spike and waves are happening. And so typically with absence seizures, this will be about 3 to 4 hertz, which means 3 to 4 spike and waves per second. And this is a pretty short one, about 6 seconds, 7 seconds long, which is often what we can see. There was a trial that was done and published in 2010 about the treatment of childhood absence epilepsy. We don't have a lot of comparative treatment trials. A lot of our treatment trials are placebo-controlled treatment trials. And so this is one, though, that was actually a comparative treatment trial between these 3 medications. They enrolled 453 children to either ethosuximide, lamotrigine, or valproate. And they had to be 2.5 to 13 years old with childhood absence epilepsy and at least 1 seizure on EEG captured lasting more than 3 seconds. And these are the doses that they targeted to in the trial. And then what they were looking at was freedom from treatment failure, defined as, how long until they had another seizure. They were also looking at secondary measures of attention due to concern that sometimes our medications can also influence things like attention, and also wanting to look at that, or the concern that frequent seizures could influence attention and learning as well. And so here's one of the first tables from that study. And you can see up here on the top, there's a column for the ethosuximide, the lamotrigine, and then the valproic acid. And the treatment failure. So when you look at that was for the ethosuximide, about 47%, the valproic acid, 42%, and then it was higher for the lamotrigine, so 71%. And they break it down on that table about, did they fail because they had seizures on only the EEG and they didn't have any that you could see, or was there both of those things happening? And or if seizures came out with hyperventilation, so with fast breathing, that can bring out seizures as well. And I think that's a lot of information. So one of the things that I liked was this table that they put in, which was that freedom from treatment failure. And so what this looks at is when you look out across those lines is how many patients were still free from treatment failure. So seizure free with each medication. And you can see that valproic acid and ethosuximide were actually more effective than lamotrigine in this study. And so valproic acid was actually most effective at 58%, at the final outcome, ethosuximide 53%, and then lamotrigine. That said, when they looked at side effects, they were most reported with patients who were on the valproic acid. And so that's something that just sometimes, even though we have this data that plays into this selection of which of these medications should we consider, is there was a little bit more side effects reported by patients with valproic acid compared to the other two. But you can see here kind of that breakdown, depending on which side effect you're most worried about, which would it be lower with out of these different medications. So I think it's nice to have that comparison between our medications with a specific epilepsy syndrome to try and help guide which of those treatment options to consider. And so this is just from the first, the primary author on this study, a quote from the study where, they really outlined that ethosuximide and valproic acid were significantly more effective than lamotrigine. They felt like without intolerable side effects, and that ethosuximide had a smaller negative effect on attention compared to valproic acid. And so again, for many patients with childhood absence epilepsy, based on this data, ethosuximide tends to be the first medication that we'll pick because of these reasons. Another medication that many of you guys have probably heard of is Levotoracetam. And so this has become a question of, well, what about Levotoracetam? This was a newer medication. It wasn't, that trial that I told you about was published in 2010. And Levotoracetam was not a part of that trial. So can we use this medication to treat childhood absence epilepsy? And so University of Michigan under Dr. Schellhaus did a retrospective review of patients with typical absence epilepsy, prescribed Levotoracetam as either initial monotherapy or add-on treatment. And they found that the Levotoracetam really wasn't very effective, and was discontinued about 74% specifically for the absence seizures. So there was incomplete seizure control in about 59%. There's other studies that show that levotoracetam is effective for, other types of epilepsy syndromes. And again, it wasn't, some patients did respond to it. It just had incomplete seizure control in a little bit higher percentage than we would hope for. But they did look at that to try and, get at the answer, well, are there any of our medications that weren't included as part of the childhood absence treatment trial that we should be using more frequently for this type of epilepsy? All right, and I just wanted to spend a little bit of time on that with treatment, because I think, those type of trials, like the childhood absence treatment trial, are things that I hope we can have again with more of our epilepsy syndromes, so that we have more definitive data about what is, going to be most helpful when we're comparing our different medications. And so I wanted to highlight that that's there, but I know that we need more trials like that to help guide our patients and families about these decisions. Another type of epilepsy I want to mention on is epilepsy with myoclonic atonic seizures. It's used to be called DUS syndrome, or DOSA syndrome is called. It tends to have an early childhood onset, typically peak onset's about 2 to 4 years, a little bit more frequent in males, with normal development before the onset of seizures. And then unfortunately, as seizures start, development can start to plateau. There's often imaging is normal. There can be a family history of epilepsy or febrile seizure. And there are some genes known to be associated with this. I think, from a genetic standpoint, there's several genes that have been reported. And so that's something to consider with this epilepsy syndrome. The classic type of seizure is what's in the name. So a myoclonic atonic seizure, where they have a jerk, so a brief myoclonic seizure, and then lose tone and often fall forward, which is the atonic component. But they can have other seizure types as well. This is a type of epilepsy that's considered on that spectrum of epileptic encephalopathy, like I had mentioned earlier, or developmental epileptic encephalopathy. The other one, sorry, I didn't highlight it when we did that one, was Gervais syndrome, would also be along the spectrum of a developmental epileptic encephalopathy. But this is much more rare than when we were talking about childhood absence epilepsy. So it accounts for about 1 to 2% of childhood epilepsy. And often the first type of seizure is a tonic-clonic or a febrile seizure. The EEG can be normal at the beginning and then tends to develop generalized spike and wave and polyspike and wave discharges, which is what's shown on the picture here at the bottom is a spike and a wave that we see there. There's many different treatments that are considered. There can be this kind of what's called a stormy phase where there's lots of seizures and it may seem like some of these different treatments aren't helping, but valproic acid is often considered, felbamate, rufinamide, ketogenic diet is something that can be specifically effective even after having tried anti-seizure medications without benefit. And then I listed some other treatments too. So sometimes we will try steroids, ethosuximide, levotoracetam, additional medications. The prognosis of epilepsy with myoclonic atonic seizures is one that typically seizures remit or resolve in about 2/3 of patients. There's some features that may suggest that seizures are going to be less likely to resolve, and I've listed those there. Up to half will have normal development or mild cognitive difficulties. And so we're often really trying to focus on how do we, preserve development and learning as much as possible and get their seizures under control to maximize those outcomes. There's certain things that can be associated with more of a poor outcome, such as having periods of non-convulsive status epilepticus or prolonged kind of absence type seizures or myoclonic seizures, abnormal development at onset. And I mentioned that because I think I told you guys that typically with this type of epilepsy, development is actually normal at onset. And so if development is abnormal at onset, it may suggest a different syndrome called Lennox-Gastaut syndrome that can also present around this age and have similar types of seizures. Multifocal spikes can also be associated with more of a poor outcome. And when I say poor outcome, meaning maybe they don't outgrow their seizures, maybe there's more trouble with learning and development. And there is some suggestion that this can be along a spectrum with Lennox-Gastaut syndrome, which is abbreviated LGS, like I have there at the bottom. Again, some of our epilepsy syndromes overlap, and sometimes it's hard to know early when seizures start what type of epilepsy they're going to have, because things can evolve a little bit over time. And so a third epilepsy syndrome diagnosis is received on average within 10 years after onset. And that's something that was done from a study that we did here at Children's Colorado, looking at our patients that were suspected at some point to have epilepsy with myoclonic atonic seizures. And we found that those patients had changes in their diagnosis sometimes over time, that again, as either additional seizure types became present or their EEG changed, it was felt that maybe they didn't fit as much with what they had initially, type of epilepsy syndrome they had been diagnosed with, and it can change. And so that just highlights some of the spectrum between the two. We also found, and so in this paper, we looked at epilepsy with myoclonic atonic seizures, LGS, so Lennox-Gastaut syndrome, and other types of epilepsy to look at how much of these different features overlap. So these paroxysmal fast activity, slow spike and wave, and tonic seizures are things that are highlighted on the bottom and are things that we looked at to see, how many of these different traits are seen in each of these conditions, knowing that there are some overlap. And people who have Lennox-Gastaut syndrome tend to have all three of these traits. That's the purple category, compared to some children who have epilepsy with myoclonic atonic seizures may have some of these features, but have a less number that have all three of them. But again, it shows that there can be some overlap. And patients who had less of these different traits that were listed over here tended to be more likely to remain to become seizure free. So the more of these traits that you have, it may be less likely that you'll become fully seizure free. So those are those things that we try and keep in mind to help guide us as, parents and families are asking very important questions about, what's going to happen long-term, what's going to be the prognosis of my child's epilepsy. So trying to help, guide those discussions a little bit more. The last thing I want to talk about is another type of epilepsy. And some of it is a specific epilepsy syndrome, but also kind of a more broad clinical definition. So something called new onset refractory status epilepticus, or NORS. This is something that can happen in adult and pediatrics, and so is not age dependent. And this is for people who do not have preceding epilepsy or history of seizures and come in with prolonged seizure activity that doesn't respond to our anti-seizure medications. So continual seizures despite 2 IV anti-seizure medications. And there's a variety of reasons that this can happen. So sometimes it could be infectious or a viral meningitis or encephalitis or autoimmune mediated, and the causes for it vary in adults compared to pediatrics. Sometimes there's a preceding febrile illness starting 2 weeks to 24 hours before the onset. So it can't be present, only one hour before the onset of the seizure. It has to be longer than that. And that's called a condition called FIRES, or febrile infection-related epilepsy syndrome, which is a subtype of NORS. And I just mentioned this because this is a newer kind of distinction about thinking of this. And this is another condition where we're learning more and may have some different treatment options down the road. And so this was the consensus definition by Dr. Hirsch that was published in 2018. The course of NORS and FIRES is that you have this acute phase where you have these really, really difficult to control seizures that's here in this acute phase, and are often tend to be in intensive care unit for a prolonged period of time, needing treatment for their seizures. And then they go right into having epilepsy that tends to still be difficult to control and can have some associated cognitive impairment, behavioral disturbances, and even death. And so I just like this figure that kind of outlines the course that we see with this. The seizure treatment in the acute phase, it tends to be that seizures are pretty hard to treat, but there's some newer data looking at different inflammatory pathways that may be related in this condition. And so we're considering some new treatment options in this condition that maybe will help improve outcome long-term. The average length of stay for people who present with NORS is about 1 month. In the chronic phase, so, maybe as I'm talking about this, you're like, well, gosh, that sounds a lot like what happened to a family member of mine or my child. In the chronic phase, what we know is that typically patients are needing multiple medications to try and control their seizures after discharge. Unfortunately, there's no trials of the most effective treatment during this phase, contrary to what I was talking about childhood absence epilepsy, where we have a trial that compares these different treatments. We don't have this for this condition. We have some case reports about what might be helpful in the chronic phase. So there was a report about cannabidiol, vagus nerve stimulation, responsive nerve stimulation, which I think you guys may have heard Dr. Joshi talk about before me. Anakinra has been used, which is a type of immune modulatory therapy, and then deep brain stimulation as well. The outcomes historically from data about 10 years ago is that patients are, as you can expect after having kind of prolonged seizure activity, that, some patients don't survive, so death, like I had mentioned, and then some patients do have a normal outcome, but that number is pretty small. And what we'd like to do with some of the research and multi-center research that's happening is to expand that number who have, a more positive outcome, normal, or, just some mild changes. And so really trying to work to expand the amount of that pie that's taken up by the normal mild outcomes. There's several questions that remain unanswered in NORS and FIRES. And I just put these here to kind of let you guys know that, and this applies to some of our other epilepsy syndromes too. I think there's several unanswered questions about a lot of these. What treatments are the best, for NORS and FIRES specifically? Does earlier control of seizures improve long-term outcomes? We think that they will, and there's some data to suggest that, but, will early treatment with targeted therapy improve long-term outcomes? What medications are most helpful in the chronic phase? How can we most support families and patients in the transition to home, and what is the best rehabilitation model to maximize recovery? So there's some collaborative research with patients, families, and physicians to help improve outcomes in this condition. And I know there's collaboration for other conditions too. I think on the one of the last slides, I mentioned some of the organizations where families are, working with physicians to try improve outcomes and improve treatments. And I think that's such an important part of what we do, is working together. And so I just wanted to highlight that here. For the different epilepsy syndromes, I wanted to refer you guys to this website from the International League Against Epilepsy. Again, I only did a smattering of them. There's many more epilepsy syndromes I didn't talk about, but if you go to epilepsydiagnosis.org, anyone can log on and you can look and be like, well, I think, they mentioned this, and you scroll to childhood or adolescent or neonatal, and I'll list the different epilepsy syndromes, and you can get some additional information about them if you want to look at that as a resource. Here's some other resources that I listed. Again, I did not list all the great organizations that are helping our patients and families with epilepsy, but just listed a few based on some of the conditions that we talked about. And then there's maybe a few minutes if anyone has any questions. And again, I apologize for the trouble with the slides, but hopefully you guys have been able to see everything at the end. All right, I think there may be a break before the next person hops on if no one has, if no one has any questions. If you guys do have any questions that come out, hopefully, you guys can type them in the chat or anything, reach out to your doctors, and hopefully they'll be able to help you get the answers you guys need. But again, I want to thank you guys for your time and your patience with the audio difficulties.